So is everything okay?
Okay, so good afternoon, everyone. Good finish. I'd like to welcome you all to the lecture contest of the mid-year meeting 2016 of IADS in Slovakia. I'd like from you to enjoy our fruitful program or our fruitful lecture contest in which we're going to have many amazing speakers, and at the same time we have an amazing judgment committee in which they will judge the lectures upon their own criteria. And we're going to start it now by a speech with Andrey. You can go ahead.
Thank you. Thank you so much. I'm so glad to see you all here. Welcome to the 15th IADS lecture contest. And at the first point, I want to explain what the lecture contest is. Lecture contest is a scientific event which is held by IADS twice a year during the mid-year and annual meetings respectively. And the purpose of this event is to encourage and to engage undergraduate students and fresh dental graduates to participate in scientific activities, to develop themselves as a scientist. And it's the first step for many of the participants here. For someone, it is their first international presentation. And today the contestants will be evaluated by a respected jury, which consists of 3 people. The first one is Dr. Andrey Baltaev, graduated from the Faculty of Medicine at Comenius University in Bratislava, and he's a co-founder of the Slovak Society for Regenerative Medicine. The next one is Dr. Darren Weiss. Probably you attended his lecture about the Humble Smile Foundation yesterday. He's graduated from 1981 from the University of Melbourne, and he's the head of a Humble Smile Foundation. Okay, the next one is Dr. Emine Karsli, who graduated from Ancient University, Cairo, and currently he is a doctoral student at the Faculty of Medicine in University of Bonn, Germany. Right? And I want to remind you that the first winner of our 15th IADS lecture contest will get a pair of dental loops from our sponsor, UK Loops Company. They've been supporting our events since 2013, and they provide quality loops at affordable prices. Okay, and about the publication, the contestants of today's lecture contest will be able to publish their full text articles in the Dental Students Research Magazine, which is the official publication of International Association of Dental Students. All right, and I want to remind you about the rules. Each contestant will have a 10 minutes for presentation plus 5 minutes for questions. So please do not exceed these limits. So I'd like you to welcome our first contestant. Her name is Tatiana Fedotova, and she will present her research, which title is the Dental Care Medications for Pregnant.
Hello, dear friends, dear judges. I'm very glad to perform here today, and today I'd like to speak about dental care medications for pregnant. The life of pregnant women differs from the life of us now, and there are they give up lots of things because they think that it can be somehow harmful for their baby, and some of these prohibitions are scientifically proved, but others are just superstitions. Lots of women avoid also dental treatment. That's why they provoke serious complications, and they, when they suffer from acute pain, they go to the dentist and they have to be treated more radically using various medications. But the problem is that dentists are sometimes not sure which medications to choose for pregnant that could be safe and effective at the same time. That's why the aim of this study, next one, was to investigate the acceptability of prescription of non-steroid anti-inflammatory drugs and antibiotics depending on terms of pregnancy in dental practice. Next one. In order to reach this goal, several databases were examined. Mainly it was PubMed, but also some other electronic issues and also printed journals. But I have to say that there was lack of clinical researches on this theme. That's why the study was based mainly on case reports and guidances. Next one. When the dentist has to choose medication for pregnancy, he or she has to take into account lots of factors, beginning from drugs capacity to cross the placenta to mother's to-be genotype. In order to make this choice easier, Food and Drug Administration created such a classification where they put all the medications for pregnancy into different categories. To A, they include those who are absolutely safe. To B, those medications that have no evidence of harm. To C means that this drug has potential toxicity or teratogenicity. D means that the drug has its side effects, but sometimes it can be used because benefits can outweigh potential harm. And to X, into this category, they include absolutely contraindicated drugs. But this classification has its disadvantages because one medicine can affect fetus and mom differently on each stage of pregnancy. And as there are no clinical trials undertaken, they usually include medicines in category B, but not A, or rather C and even D. Next one. That's why to prescribe anything for pregnant patients, we have to understand physiology of pregnancy. There are some critical periods when fetus is more likely to be affected. The first one is on the 7th, 8th day. It is hard to believe, but in this time, more than 50% of cases ends up with spontaneous abortion. Next one comes when main organs are formed, and finally, period of placentation. And the best time for treatment is early second trimester. Next. So that's why it is important to take into account the stage of pregnancy. Next. All these critical periods are situated in first trimester of pregnancy, and that's why the list of medications here is quite short. Next. Among analgesics, the most safe is paracetamol on each stage of pregnancy. All the others appear to be better avoided because they can cause spontaneous abortion. Especially dangerous is aspirin because they may cause some special complications. Among antibiotics, the best choice is next slide. Oh no, previous one. Penicillins, cephalosporins, and if there is allergy or they are not effective enough, you can use erythromycin as well. Conversely, the most dangerous are antibiotics from tetracycline group. Also, you have to avoid prescription of aminoglycosides because they may damage 8th part cerebral nerves. Fluoroquinolones cause alpha-1 in animal models. And all the others that you can see here should be avoided because of their potential toxicity and teratogenicity. In second trimester, placenta is formed, fetus becomes more defended, protected, and that's why you can use alternative medications. For example, they are naproxen and piroxicam among analgesics. It's interesting Analgesics are contraindicated, but there are special complications such as intrauterine growth restriction, low birth weight, and they noticed also the fact of diagnosing bronchial asthma in 18-month-old kids when their moms were taking ibuprofen in second and third trimesters. Among antibiotics, you can see that metronidazole is no more contraindicated. It can be used in some cases. Also, you can prescribe clindamycin and azithromycin. In cases of severe infection, you can use gentamicin and vancomycin, but they are potential toxic and that's why you have to weigh on one hand benefits and on another complications to decide whether to use it or not. And in third trimester, fetus is almost completely developed and is ready to born and can be born alive. Among analgesics, non-steroid anti-inflammatory drugs should be better avoided because they can lead to premature closure of ductus arteriosus, uterine and postpartum hemorrhage, and cause dystocia. On the late stages of pregnancy, also they do not recommend to use sulfonamides because they can lead to current pictures besides their allergenicity. To sum up, I put all the indications in such a table where you can see if you can use them, green color or not, red color, and yellow means that you have to decide on your own whether to choose it or not. Next one. Here you can see that I put them into 4 groups. The first one is here you can see the medications that are recommended to be used on every stage of pregnancy, and if they are not effective enough, you can use medications from the second group, but only since second trimester. And next groups are better to avoid.
All right.
Thank you.
So does anybody have any questions? You feel free to ask.
She didn't speak about most important point is the anesthesia.
It wasn't my aim, but
Because
I can answer your question because
is pregnant, which anesthesia you prefer to do, and can you do with anesthesia?
Yeah, of course. It wasn't my aim. That's why I was not talking about it, but I think yes, it's a very interesting point. And if you choose anesthesia, it is better to use the solution of 2% lidocaine with adrenaline, as they use in the USA, as I know, because lots of reports are only about this. Yes, but for example, in Russia they use the solution of 4% anticaine with adrenaline, and it's very good. I think it is the best choice for everybody because, and it is very important to choose the right amount of adrenaline. It's 1 to the best choice is 1 to 2 or 400,000. Yes, and it's you shouldn't use mepivacaine. You shouldn't choose it because it's toxic and it crosses placenta and can affect somehow the fetus. And you also I recommend not to use more adrenaline that I said because it can cause uterine restriction. Yes. And as for what?
Like if a woman she's pregnant, can she do a panoramic radial? Or
Yes, X-rays. Yes.
Yes, that's how
This is
also very similar about the
it's
pregnancy.
a different question, so you may.
Things go easier.
because it's a care, like medical care.
medical dental care medication.
But
you can use
It's water bubble.
you can speak about breathing.
Yeah, we can have a discussion.
In another
afterwards.
session.
It is not related to the topic of the thank you, Tatiana. And please welcome our next contestant, who is Alessandra Hajdo, with a presentation about the use of Propolis in treatment of oral lesions.
Good afternoon, everyone. My name is Alessandra Hajdo, and I'm from Poland, from that country which I hope to see all in September 2016 for FDI. I'm a dentist, but I'm also a PhD student. And today I would like to talk to you about the use of Polish propolis in treatment of oral lesions. But let's start from the beginning. We are living in 21st century. Day by day, by means of the newest technology, are invented very complex and sophisticated medicines. Unfortunately, conventional pharmaceuticals, of course, they play a huge role in medicine, have been overprescribed and overused in the last decades. But thankfully to the nature, smart mother nature, has provided her own wonderful, powerful medicine, which is propolis. Propolis is a germ-killing substance that is manufactured by the species and the smallest creatures in the world, bees. For 1,000 years, propolis has played a huge role in humans' health. It was first mentioned by Aristotle, and then even the father of medicine, Hippocrates, was using it to cure open sores and ulcers. Propolis is a complicated mixture of substances that are collected by bees from nature, from plants. It's known also as a bee glue, and it contains more than 250 compounds. Those I would like to emphasize are vitamin A, B, C, selenium, magnesium, iron, antioxidants, biotin, amino acids. But the one that provide those miraculous curative properties is caffeic acid phentyl ester. Biological activity of propolis distinguished from which area, from which zone, when, from the season of the year, is collected by the bees. I'm concentrating today the one from Europe and Poland. Propolis has properties as antibacterial, antiviral, fungicidal, anti-inflammatory, antioxidative, immunomodulatory, and anti-cancer. And all of those properties are used nowadays in this district. Cardiology, it slows down production of acid by Streptococcus mutans. In oral surgery, in endo, in restorative dentistry, even in orthodontics. But I'm gonna talk today about perio and oral medicine. The objective of my investigation was to prove the effectiveness of propolis by treating patients with ointment that contain propolis, but also spray and some mouthwashes. Now I'm going to show you one picture of the patient that has been among this investigation, but afterwards the one which I think is the most interesting. So I gathered around 30 patients with oral lesions, different origins, viral infection, mechanical trauma, gingivitis. The patients ranking between the age of 25-70, and what is very important, they were not allergic to bee products. Here we have the patient with gingivitis. As you see, he's already hiding. I think I don't have to speak much about it, but he presented to dental office because he was bleeding while brushing, has pain during brushing, and as you see the symptoms of the swollenness and of the redness, and few days of using it, even if he didn't improve his oral hygiene that much, we see improvements of the mucus. Among those 30 patients, treating each of them end up successfully. Again, we were using spray, ointments, and mouth gargle that are over the counter. But the case I would like to show you today is I have a patient, male patient, 13 years old. The boy is taking steroids, huge doses, and I diagnosed steroid-induced oral candidiasis. He's not allergic to bee products, and the treatment involves still, because he's still ongoing treatment. Anti-gluten diet, we excluded milk. Dairy-free diet reduced carbohydrates, and included, of course, Propolis products. On the buccal mucus, we see the oral lesions. I was trying to scratch them, but they were not coming up. And the other side is like that. I was thinking, okay, he wears braces. Maybe this is like stain for braces, but no. And I recommended daily 3 applications of Propolis. And this is how it looks like right now after 3 weeks. He's not cured, totally. But Propolis does not have nearly any side effects. He's taking huge doses of steroids. I wanted to avoid to damage, to make more damage in his organs. So we didn't influence liver or stomach. And the other side. 3 weeks now. Those pictures were taken last week, I think Wednesday and Thursday. And he's still ongoing. I haven't decided yet how long it's going to take the treatment, but he can keep doing it because there are no contraindications to stop it. And I just want you to tell you that Mother Nature is wonderful, and we have things like Propolis, which is very promising in medicine and should be reintroduced because it's been known for years to oral hygiene and can help in good oral health maintenance. And now we should switch on to the back to nature approach, where Propolis seems to be a promising alternative for the control of oral diseases in terms of antimicrobial response and lower associated risk. Thank you.
Thank you, Alessandra. Does anybody have any questions? Anyone?
Did you have a control group in all the subjects you mentioned? Did you have a control group that was not treated at all?
No, I was just comparing to the publication because I don't want it to be substitute. I want this to be like something extra because some of the patients are taking a lot of medications, and if we don't want to do any more damage in the body, I think it's a good idea. Thus, I'm not telling to exclude the medication. It is something extra.
So is it, you use the Propolis as adjunctive treatment? Adjunctive treatment?
And you can use like stronger. Because
Do you use it?
do I use it? Yeah. Like my patients.
Just one treatment or adjunctive treatment?
It depends. Like with patients with gingivitis, with oral lesions, I'm always telling them to use it. Even when I take it after this.
Just alone?
I will try alone. If I don't see an improvement, then I'm taking something stronger.
Thank you, Alessandra. Okay. Little brighter.
Okay, so maybe you said you use it in the form of ointment, spray, and solution.
And mouthwash.
Yeah.
Mouthwash.
So
But there are more.
the concentration is the same, or you have to change the concentration.
Okay, those are the one you can get like on daily basis in a super farm like cosmetic shop in pharmacy. You can make your own tincture, which is super strong, super high in concentration, and they use it, for example, in Turcica, the inflammation after the extraction. Latin. And yeah, and the different because the one which you can get on daily basis, they are among 5 and 7%.
But what I want to reach is what is the minimum effective dose of Propolis? I mean,
there are no publications on the one which is minimum I found is 5%. As in my mind.
please.
You had a picture of braces and lesions on the vestibular mucosa. And they look like from the braces, but you said no.
No, they were not from the braces.
How did you find that?
First of all, signs like that on braces it would hurt him. And I knew before he came up to the dental office, his internist prescribed him like twice dosage of the normal steroids. And later on, and I said, like I showed to the mom, like look what's going on. He went to his internist and he said yes, it's because of the steroids. And this is, we know it, the side effect of taking steroids.
Okay, thank you, Alessandra. And please welcome our next participant, Betul Gedik, with her evaluation of dental caries and dental trauma in patients with visual impairment.
Hello everyone, I'm Betul from Istanbul University and today I will present my project about pediatric dentistry and visual impairments. And my title is Evaluation of Dental Caries and Dental Trauma with Visual Impairments. But first of all, I want to tell you what I'm going to talk about. Definition of visual impairments, awareness and different approaches, caries experience and trauma history as a result, recent studies, and finally conclusions. Yes. According to World Health Organization, disability means any restriction or lack resulting from any impairment of ability to perform an activity in the manner or within the range considered normal for a human being. And visual impairment means partial or total loss vision due to a medical condition such as congenital conditions, birth trauma, disease or injury causing the ability to function normally. And as dentists and dental students, what we can do for these special cases, we can arrange short appointments and a clear ongoing description on what they would feel, taste, or hear, and smell is so important. We can let them touch, smell, taste instead of tell, show, do technique. And it may be also useful to allow patients to touch instruments, what we can use on them, and to explain direction as some patients rely on senses. And movements should be explained and then carried out in a slow and deliberate manner. And I found a fund research that should indicate that fear and apprehension might be reduced by the encouragement of questioning by patients. And about my research, the aim of this study is to determine the prevalence of caries, dental trauma stories, and oral hygiene studies of visually impaired students. As material and methods, we are a school club in Dentistry faculty of Istanbul University, and I am the president of it. Last year we went to a school for blind and visually impaired students, and 130 students of Turcica School for the blind and visually impaired were examined under sunlight to evaluate their caries and dental traumas. We also gave them oral motivation for healthcare. And as material and method, we use dental visit kits, disposable and sterile, made by 3 items such as mirror probe and tweezers in plastic material. All sterile kits were single packet for each individual. We also use some questions, but it's unfortunately Turkish. We just can't explain you. We didn't want to use cases treat orthodontic treatments for orthodontic problems or dental anomalies. So we just took some patients, some students without orthodontic treatment, orthodontic problems, and dental anomalies because we wanted to evaluate their dental caries. And this is the main method, DMFS indexes we used for dental caries again. As a result, the clinically examined sample consists of 66 boys and 64 girls, almost 50-50. And age range of the study participants was between 6 and 21 years with a mean age of 9.9. And overall prevalence of 78.4% caries experiences was found in the study population with no significant difference between girls and boys. And we also had 8 students have trauma histories. And as a result, we can say caries prevalence and severity in visually impaired children were very high, and the number of children with good oral hygiene was very low, significantly. And after all these results, we can tell visually impaired can have a negative effect upon oral hygiene, in addition to the common factors such as lack of medial visual coordination of the blind child and the child's reduced concept for her or his appearance. And there may also be an increase in periodontal disease with higher levels of calculus and debris than those who lack a visual impairment. But we found out that given adequate verbal expression, individuals with a visual impairment can have the same level of oral health as the others. That's why we wanted to give them oral motivation for oral health care. And if you look at the recent studies, Nandini found 37.3% dental caries experiencing 150 students, and Carter and Wagner found 78.9% dental caries experiencing 185 patients, and Mekiroğlu found 73.5% dental caries experience in the 178 patients, but our results were so higher than that. And about dental trauma cases, traumatic dental injuries are common among school children with a prevalence range from 6.19% to 58.6%. Children with disabilities are considered to be at higher risk for traumatic dental injuries, but according to recent studies, we found less trauma presence, but we can say the number of researchers are not enough for now. We can do something more to stop. And as previous studies show, trauma reasons of the children which we had examined are falling in the house or outside or bumping somewhere, but fall being indoor was the most common reason. As conclusions, higher cavity prevalence and less traumatic teeth than rated on literature results were found on visually impaired children. It should be benefited from sense of touch and verbal expression by the brushing, teeth education, oral health motivation to children. And this is my team from last year. Our director, Emine, from here. Thank you for your kind attention.
Thank you, Betul. Does anybody have any questions?
This was just to evaluate their prevalence and take care of them. So if you have a question,
It's very well structured. I'm just curious, you presented some citations where it was results about caries.
dental caries and
Yeah,
trauma
some
histories.
publication in 2003, 2009, and 2012. Where is it having the same population, like Turkish population, like?
No. One of them were Turkish, one of them from Germany. I didn't know.
So which one was the Turkish?
Betul. The last one.
Okay, so you're having nearly the same result.
Yes. What we found. So, thank you again.
Thank you, Betul. And please welcome our next participant, Elio Boschetti.
No, we don't have audio. No possible. We have audio. Can I switch you to somebody else? Otherwise, it's okay. So, hi, good afternoon. I am Andrey Baltaev. It's a great pleasure for me to be here to present to you, to share with you my research that I did cooperating with 3 different universities. And it is going to be published pretty soon, hopefully. So let's start. Just 30 seconds to introduce myself and also this research. So that's my hometown. It is named Vicenza. Yeah, that's yes. It is where I'm living, where I'm working. It is my university where I graduated and where I'm still working. It's okay. Where I'm working 1 week a month, and it is McGill University in Montreal, where I did an internship as a researcher, where I did actually this research. And also the last one is IADS University from Switzerland, but actually they are establishing 2 amazing international specialization in orthodontics and in surgery in Malta. So these studies want to evaluate how well the new Invisalign, the latest Invisalign works, comparing the predicted outcomes to the actual real outcomes. So, as you know, it is we are working on this every day. So, human eyes and smile are the part of the face that transmits emotion. So, they have a really large impact on patient's life and also in the relationships. So, having the ability, the knowledge, the skills to change it, to make it more harmonious, can really change the patient's life. So we know from the literature that the presence of malocclusion can affect the entire face, So an orthodontic correction of malocclusion can really improve the aesthetic of the overall face. So, and we know also that a poor dental condition is often perceived as also a poor social performance and also a poor intellectual ability. So, and moreover, always from the literature, we know that a person with a nice smile, a healthy smile, it looks more intelligent, but not only, he has also more probability, more chances to find a good job, actually. So, for many reasons, the adult demand for aesthetic orthodontic treatment is increasing. But adults really prefer to undertake an aesthetic orthodontic treatment, not braces. In fact, 97% of the patients wish to undertake an orthodontic treatment for aesthetic reasons, but 62% of them refuse braces because they find them unacceptable and unattractive. So patients are willing to pay more money to have an aesthetic orthodontic treatment. So companies have made many efforts to increase the aesthetic in orthodontics. So now we have, So now we have ceramic and plastic brackets, lingual orthodontics, appliances, and also clear plastic trays. So there are many articles in literature. They compare these appliances, and patients always gave the maximum score, the best score to the aligners because they are invisible, comfortable, and removable. So as you can see, this patient Marco can speak, laugh easily, and no one is can guess that he's undertaking ortho treatment. So Invisalign, we know from the previous literature that Invisalign is successful for treating mildly crowding and spacing, deep overbite problems, not skeletally constricted arches, and mild relapse from previous orthodontic treatment. And it is they are difficult to improve crowding and spacing more than 5 millimeters. And anterior-posterior discrepancies, as for instance, for extractive case or orthodontic surgery is not really indicated. And for rotated teeth and open bite and teeth that have some short crown or missing teeth. So all previous studies were conducted with the aligner fabricated with a previous material named Exist30, and it creates some really high forces and moment. But after just few days, they have an exponential rapid decrease. But since January 2013, Invisalign has been made with a new material named Smart Track. And there is no independent report until now. So it's going to be the first publication about this new material. So we selected 35 patients that, of course, they studied the treatment after January 2013 with a DI score less equal than 15. Class 1, 2, and 3 of angle malocclusion were included, as well also mild, moderate, and severe dental clothing and spacing, but they didn't require extraction or orthodontic surgery, and of course they had a really good compliance during the treatment. So every patient underwent to the Invisalign protocol. So we took the extraoral and the intraoral pictures, the PDS impression, and also, of course, the X-rays. And we sent all of this stuff to the Align technology, and they send us back the CleanCheck Pro. It is the software where the doctor can plan the entire treatment, right? And so you can move all the teeth. You can decide how every single aligner has to. Oh, your battery is running out. Yeah. So, and really, for people that want to work with Invisalign, just don't trust the definition. You are the doctor. You have to do it, right? So it's really important. And now we can see how attachment works. They are really essential and some really difficult movements. And it's really important to do the recall and just checking that everything is going in the right way. Only in that way you can achieve really good results. Otherwise, it's kind of difficult. Okay, so all parameters were measured from 4 blinded investigators, and as I told you before, we compared the pre-treatment, the predicted outcomes, and the real outcomes. So we also considered the IADS Efficacy Index from American Board of Orthodontics, and so. Here our results. You can see here the number and the percentage. Can you please switch on? Yeah, thank you. So we can say how the percentage of the accuracy, the predictability of the therapy. So we can say the rotation, the clothing, and the spacing. They are really, really good results. This one is much better than the previous literature, but it's not. We are not really, I can say, happy about the overjet, overbite. And I think that the eye is pretty good results. So, but okay, so we saw that the overall efficacy of the tooth movement was 67%, and also the CleanCheck Pro accurately predicted the change of midline. So we can say that the strengths of Invisalign are the ability to close the spaces and to manage the clothing, and the concordance for the discrepancy index, as I told you before, was 57%. And we noticed this side effect, but it did not affect the occlusion significantly, because after just 2 months, you can see the re-exclusion and everything will be fine. So our greatest result, you can say our results compared to the previous literature, how much well this new material works than the previous, in particular for the teeth rotation. You can see in particular for the canine and for the premolar, we had a really, really great result. So in conclusion, we can say that the latest Invisalign is definitely a good orthodontic appliance. But it has really to be studied and understood, because as I show you, it has some strengths, but also it's not really good for some kind of malocclusion. So thank you very much.
Thank you, Elio, for this amazing presentation. So does anyone have any questions for our presenter?
Yeah, sure, with pleasure. You know, because I saw that I was late, so I tried to go through faster.
That's the calculation of efficiency.
Yeah, right.
Yeah,
if you can find on. We need the statistics calculation. Actually, a statistician did it. But what I showed you.
You have STL model of the final and STL model of the refinement. You have three.
Exactly. What do you want to say? The percentage or?
Yeah, how you calculate the percentage? When you choose linear points or you put the STLs over each other and make something.
Oh no. We use look. It is a software to measure, right? Yeah. And you can exactly. So we put the STL and we measure in that way, and so we got the percentage of accuracy. I mean, we didn't do only this kind of statistics, but we made also percentage of accuracy because all the previous studies use it, right? I know that statistician told me, hey, look, percentage of accuracy is not the best stats ever, but we want to compare with the previous studies. So we use these statistics, but not only. I did not. Yeah. Yeah, I mean, what do you wanna see? I mean,
so you have the canine before.
the rotation.
The discrepancy between the planned canine position and real canine position.
How do we get?
Yeah.
I'm good at so. We, as I showed you in the video, we took the impression. So we have the beginning, and the Invisalign send us the software with the STL, right? Yeah, exactly. And then with CleanCheck Pro, I mean with the Invisalign software, you can see that the old treatment that you and the technician planned. So we took the end of the treatment, right? So the predicted outcomes, and when a patient ended, we retook an impression. We sent Invisalign, they send us back another STL and we compare, right?
Yeah. Okay. What I'm asking is how you compare the model number 2 and model number 3. How you compare?
Oh yeah. No. We measured with for instance the rotation. We took I can show you here. For instance, for the rotation, we are here. No, we just measured. We
choose one point.
Yeah.
Let's say it was supposed to be here and it's here, so
every measurement is each other because, for instance, for cloning and spacing, we just measure the space needed and the required space and the length of the teeth, right? So we did this calculation.
So you choose different movements like rotation.
Exactly. Look, I was going super fast, but I can show you this slide. The all parameters,
We compare rotation of incisors, which is
a
very good shape, and rotation of canines.
Yeah.
There should be a difference. Canines is very difficult to rotate.
Yeah.
Much more difficult than incisors.
That's true, absolutely. But with the use smart forces, or in design, namely smart forces with attachments, and also research profession. So we have some kind of tips. For instance, when you want to achieve a really difficult movement, you can ask the technicians, hey, you just make this movement much more slow, so I can control the traction. And also the really key of the treatment are the attachment. Right? With attachment you can achieve.
That's all right. Okay. There's a question if you consider that you could distribute this research not only about movements, because they are different on different teeth. Rotation is difficult on canines, less difficult on incisors.
Right.
So not only distributed according to movements, like rotation, but some teeth are more probable. We expect the canines are long.
But let's not forget that he's comparing what their predicted outcomes are supposed to be. He's not really.
Yeah, that's what I was
right.
saying.
Look, canine, premolar, central incisor, lateral incisor. So actually, we measure them each other, right? I mean, really, can't you look at the canine premolar, central incisor, lateral incisor? So the blue is our study, and the color is
Very nice presentation. But I have only one question.
Yeah.
Is this research sponsored by Invisalign?
No, unfortunately not. It's not sponsored. And look, unfortunately, I'm not paying by. No, yeah, no, it's an independent research. And I tell you something more. At the beginning, Invisalign was helping us, giving not money, just STL5 because they don't usually do that. But at the end,
they will have, by any means, a control over the results?
No,
yes or no?
No, zero. And they got kind of disappointed when they know when they knew that we are going to publish the nice results, but also the bad results. They weren't super happy actually.
There is one more question from the
for treatments of 2 years. How many stents?
Excuse me, second.
For treatments of 2 years.
Yeah.
How many stents do you need to change?
How many appliances? Okay, so basically you should change one clear appliance every 2 weeks. But if the patient is good, cleaning well, wearing a lot, and the movement is not super difficult, you can change also every 10 days. I usually, if it's not a difficult case, 10 days, that's enough. Also because, as you saw, the forces and the moments during 10 days, they decrease, right? So,
thank you so much, Elio. I guess you're all tired and it's time for a coffee break now. So see you all in 15 minutes so we can continue our lecture contest. Thank you so much. Please, don't be late.
For dentists or for patients? For patients, that was a dentist. I mean, that is one.
Yes.
Yeah. So, the cost test, you can choose medium treatment or large treatment. It depends how difficult it is, right? So if you take just the smallest one, just 7 appliances, it's gonna cost something like dentist, 1,000. Oh yeah. So I mean, if you want to do a full case,
can you pause it for a moment?
We can. So it means that
how many people are watching
pay a lot?
4 viewers.
So I need to ask this patient at least 6,000. Otherwise, I'm not getting on, right? We have crazy taxes, crazy stuff.
Okay. So let's take this.
I mean, it depends how long is that, right? It depends how long is that. Hey, please, if you have more questions, just ask.
I'm doing this on time level. I know everything, but enough the chance to have this SEO before and after. And then there was thinking about some movements are extremely difficult, not only on the root, and they have no idea about the root.
Yeah. Look. For that we know, but it's improving a lot. I mean, when it came out in 1999, it was terrible. My mother is an orthodontist, and when it came out, I would like to work with Invisalign. So she said to me, no, they improved, and that's true. So it's good, but you have to work carefully, right? So fortunately, I have two really networks for Invisalign. One is the Persian market here from Montreal, and now he's working both in Montreal and the Dubai. And Dr. Emilio, and he's Really?
Because you go to sub-zero, sub-zero.
Yeah.
And you find very nice. Which is 0.2, you consider 0.1.
Yeah.
So you get it.
But look, why you can do it with the latest CleanCheck Pro, because with the previous one, come on, it was a little bit.
This is perfect.
I'm relating my slide, but
Yeah, that's true. But as I show you, I mean, it's not so. It's not any time. We made the percentage of accuracy or the overall treatment, and it was something like 60%. I mean, it is very good, but it's not precise enough, right?
It's a new thing.
Oh, really?
Yeah.
No, no.
It's my second play.
oh, great. Nice.
Because the ISS, space station.
Can I say this?
Yeah. I have charges here. It's a coffee break.
They find out.
Like 10.
Yeah. This slide was not that great, and I made one slide on this slide.
The US works like 1.5 years.
Yeah, it's better for online translation with the voice out, so people can better see the screen and present.
And they say,
Your price. You always want. Yes, of course. First price. Yes.
Yeah.
Special price.
But the zero place.
It's even before the first. Like this. Isn't it?
It's like suddenly it's good.
Yeah.
I hope it works.
But it's just of course, other things. Yeah, exactly. Yeah, so I have a screen here. Exactly. So that's how yeah, but that's we know first because minimally invasive. So how can you do that if you want to?
We just have to find a way.
Yeah, no, I don't know. The exams and the as with disproportionate treat the wire, and not only but also kind of natural questions.
But the same as the Invisalign or just like
no, something like Invisalign, but of course much more strong, than not the last category. So the patient has to wear it for at least, I always say, I always say, as much as you wear it, much more. But then also, I also the wire, the wire, because I don't want to relax, right? And sometimes, when patient just the wire, I saw just but maybe that's kind of
No, that's very interesting. You know, some time ago, I had a wire on my office, and even on the wire, I had the gap.
Yeah, but you know what? I think that.
And I think it helped me for me, you know. I'm pretty interested in the topic. I'm still very interested in that.
Yeah, sure.
But like for now, I was.
Yeah, but you know what? I think that every 5 years you have to remake the wire, right? Because I'm using this kind of wire, yeah, exactly. I think that is pretty good for the information. I know some people do it just with composite, but it's not gonna work because it's gonna grow away. But I saw that if you redo the convention every 5 years, much more.
But it happened like 1 month. Like they also put on braces, and I put a wire and nothing else.
Yeah.
So.
And how long does the relapse take before that you?
I mean, they took it off. I went for the weekend for a trip.
Just
And
without any convention.
Only without the
I'm telling you why.
I had a space.
I'm telling you why. Because your orthodontist should have left in your mouth the braces at least 3 months more. Because your bone was still remodeling, right? It is exactly, it is a really common mistake.
Instead, she tried to, redo this with something like Invisalign, but it was like 5 years ago.
Yeah. No.
So
5 years ago it was
5 spins, like it was something but I'm so unsatisfied.
Yeah, but it is a really common mistake. I saw so many. For the pre-prosto orthodontics or also pre-implant, when you want preserve the bone or when you can raise the bone, so you can do the extrusion, right? Okay, fine. But when you achieve the extrusion that you want, you can't just not pull out the root or the teeth. You can't because you're gonna fail because the osteoblasts they are still working. So you have to wait 3-6 months, because otherwise when you pull out the root, you're putting implant, but that bone is not so good. So it's not a mess. I remember because I saw so many. Hey, look at the first, my implant was so nice. How the session? Yeah, for sure. Come on, you have to wait, right? It's a slow therapy. Yeah, because I show you because it doesn't work, it doesn't hurt, and also it is a really low impact in the patient's life because with braces if you wanna just eat if you wanna eat a particular stick. Already are enabled like that. You can with Invisalign you can just remove, smile, and that's it. And also, it doesn't hurt. It's completely invisible. So I think that it is good. But I prefer braces.
Excuse me. But compliance. Patience.
Oh yeah, yeah. Look, the patient's motivation is the key. If the patient, I don't know, as a come you are spending a lot of money, and you're working, you know, I don't want to fail my treatment just because you are so. Think about it, you are paying me a lot because I'm paying a lot then, so, right? So think about it.
But you're designing this appliances for yourself, not just
Look,
sending
when you send the version, Invisalign send you a treatment plan, right?
I know.
Yeah, yeah. And you can just accept it, right? It's a terrible mistake because you are the doctor, you are the doctor. And so you are speaking with a technician, right? So you have to check the plan, and you can just change, move lots of stuff. You know, it is about selecting the patients, and also you have to work on it because it's not so easy, it's not so difficult to fail, right? It's a nice alliance, but I mean, I've been working 2 years in Invisalign, and I still have to learn a lot. So yeah, I mean, I like it, but you know what? I never ever accepted the just the plan that they set to me. Just because also just for my, I can say, I mean, I'm the doctor, so I really want that they know. I mean, that the Palate technology know that I know what I'm doing, right? I mean, I'm planning this, not them, right?
You're responsible.
Yeah, exactly. And the patient will complain, will be not with Invisalign, right? Yeah.
Because I know many dentists that are really orthodontic.
Yeah, I know.
And they're just taking impressions and they are sending them. So I was wondering,
you know what? Yeah, in fact, when patient comes to me to do exercise, I always say, look, you can do a treatment here, or you can do Invisalign treatment in another dental office. Fine? They think that it's going to be the same, and I'm telling them, look, it's not going to be the same, you know, because it's just, you know, right? It's a brand, that's it, right? It's a brand. So you have to plan the treatment. Okay, the technicians are good, are super helpful, you know, because they know the material, they know the stuff, they are engineering actually. So it's they are really that. But you are the doctor. So I always, I mean, maybe I didn't say it before, but for me it's really important that I mean, everyone has to know that if you do an Invisalign treatment in some days, it will be completely different from another Invisalign. Yeah, exactly. Yeah, but the people usually don't understand it, right? So I show them, they pre-check, hey, look, I'm moving, yeah, right?
Thank you.
No, thank you. Hey, how you doing?
Hello.
I'm fine. Yeah, I am here.
I'm trying to send some stuff to Portugal.
Yeah, it's your turn, right now. Man, you know what? 10 minutes. When I presented the research in I had 30 minutes.
So it wasn't once in videos.
It's super short.
It's 1 minute.
No. The first one is 10 seconds. And the second one is 1 minute. But it is you for the past. Oh yeah. Yeah, exactly. And it's you need an amazing presentation. You have yeah.
They have a click now.
No, I don't.
Yeah, these are kind of advice.
You have this there.
Yes, we do. Thank you very much. Do you have an HDMI?
Yeah, no, it was
What?
kind
No,
of
that's
because
fine.
they believe, right, it's not university. They don't even speak about
So you'll be the
not in design, of course, aesthetic work.
So the next presentation.
Yes,
it's
yeah, no, I need the aesthetic appliances, like so
that is the last one. It's one of the biggest
strong background rational, right?
Where?
That's why we in the class. I think that this arts background and rational and others.
Yes.
It's not really bad.
I think it's about 30 minutes walking, so
I
maybe we will
know,
take a
my
bus or something. I don't really know, but I hope so because
I know that it's something for you, but somehow also, right?
yes, everywhere, everywhere. Yes, it is, and for you. All right.
Yeah.
It's a beautiful city. There is all buildings and stuff. I like it. Yeah, it is. It is like 400,000. Yes, and in the whole town, go around like 1 hour and a half, and you will see everything. So, pretty small. Yes,
No,
she wanted to talk about it, she did not. Sometimes, so that's all right.
I'm great.
I wanted to talk about internships and
Yeah.
really to discuss anyway. Yes. Tomorrow will be late about 10 a.m. So yeah, I have flight at 1 p.m. So I don't remember exactly. Yes, but it will not be long. That's a short video. Before his lecture, and his lecture is at 5 p.m. Yes, maybe we can do it. Or after the lecture, if it will be possible. All right. Yes. Actually, if it's possible to get some kind of program, because okay, we agreed on the internship, but we don't really agree on what will happen to the students there. And
Maybe I think we can go to 6 without me.
yes,
The most happy.
yes. I will write down some points, some more which we should discuss.
Okay, so continue when you have the points and discuss the next. Do you have any doubts?
Yes, all right.
That way. If you wait for him to be available.
It will never happen. Okay, I understand.
Yeah, that's right.
That's what I was surprised that you It's just now that explains it. Oh, I read that. She's evolving
Currently, my therapist is Alessandra
I can't remember, it was some organization, I think it was
You're back.
So the coffee break is over and we're about to start. So please take your seats and all right. And please welcome our next presenter, Miss Emine Karsli from Turkey, with her size and morphology of Sella Turcica in cleft lip and palate patients.
Dear Chairman, the professors, and dear colleagues, thanks for coming here and paying attention to this coffee break. I'm going to present our study named Size and Morphology of Sella Turcica in cleft and palate patients. My name is Emine Karsli, as we said. Sella Turcica is a line bone formation appears on the superior surface of the sphenic bone, as all we know, and its diameter changing range 5 to 16 millimeters, and for depth 4 to 12 millimeters. Pituitary gland, such important gland, has quite important hormone it secretes, and it's surrounded by bone structures. And during the supermetric analysis, according to the reference points of the cranial and facial anatomical structures region, linear and angular measurements are made from these points, and S point is the geometrical center of the Sella Turcica. And it shows us the relations between mandible and maxilla. And also its morphology is important. It's commonly shaped U. Its shape is U and bone formation, and it has some variations like anterior oblique anterior wall, double contour of the floor, Sella Turcica bridging, irregularity in the posterior wall, and pyramidal shape of the dorsum. And in the literature, it showed that there's no relation between gender and its dimensions. And also for skeletal malocclusions, there's no relation between, according to the literature, there's no relation between skeletal malocclusions and Sella Turcica dimensions. However, for the Sella Turcica morphology, there is some variation. There's changing in Sella Turcica morphology in different types of skeletal malocclusion. And also, there is difference between center patients and normal patients, its size and also for morphology. And these are the deviation patterns with different types of centers. And cleft and palates are most common congenital anomaly in the craniofacial region, and not only the cleft region, but also peripheral regions of the front anomaly. And peripheral structures be influenced, like with cleft area, of the anomaly occurring by the multifactorial genetic and environmental factors. Sella Turcica has very important location in the migration center of the neural crest cells. Previous studies have shown the relation between maxillary development and prenatal and postnatal formation of the pituitary gland and Sella Turcica. Okay. However, limited number of studies in the literature were showed Sella Turcica's size and morphology with cleft and palate patients, unilateral and bilateral patients. Furthermore, investigations needed to give extensive information in this field. Especially, we have found no studies performed to show difference between left unilateral and right unilateral cleft palate patients. So aim of this study to compare the size and morphology of Sella turcica with two different age groups of patients have right unilateral, left unilateral, bilateral cleft palate anomaly. So cleft patients applying to the Istanbul University Faculty of Dentistry Department of Orthodontic pre-treatment lateral supermetric radiographs evaluated retrospectively. And 33 females and 36 males included our study, and patients have unclear occurrence of Sella turcica on radiograph, have any syndrome or have any orthodontic treatment excluded from the study. So, some evaluated dimension of Sella turcica reference points are tuberculum Sella, dorsum Sella, and pituitary fossa, base of the pituitary fossa, and these are how we measure these distances. And for the morphology, as I told you, we look for the different morphologies. For the statistical analysis, we choose 15 radiographs randomly, and we trace, and 1 month later we trace again, second time independently, and we look for the difference between the measurements by magnetic U test, and also looking for the difference of all these groups between each other, and we use also magnetic U test. As a result, data from the measurements of Sella turcica, all groups show increasing dimensions on Sella turcica in between, just, for example, left unilateral group and right unilateral group with different aids, and also for bilateral group and also for controls. There's no really interesting thing here because they already showed in the literature, and we compared its size in between younger age group in cleft groups. So there's no significant difference between groups. But however, when we compare with the control group, there is significant difference between control group and cleft group, especially for the depth and diameter, and for the left unilateral group for all measurements. For the older age group, we compare between each other, and we compare with these cleft groups in each other. Right unilateral patients showed bigger dimensions, especially for diameter. However, when we compare with the control group with the cleft groups, left unilateral and bilateral cleft groups showed smaller size with the control group. However, no difference between right unilateral cleft groups when we compare it with the control group. So, when we look for the morphology, different from the normal Sella in cleft subjects. However, when we look for the control group, the percentage of normal Sella was 66%. However, the abnormal morphology we showed with our study, pyramidal shape of the dorsum Sella in left cleft group, irregularity in the posterior part in right cleft group, right unilateral cleft group, and for bilateral group, Sella turcica bridge was more common. When we look for the older group, this is our really interesting result, because for me, it's the same for the control group, but we can see the normal morphology is increasing with the older group. It is really interesting. And we have decreasing percentage for the abnormal morphology. As a discussion, as I said before, gender and different skeletal malocclusion plays no role in Sella shape. However, the morphology of Sella turcica reported not to change significantly after 12 years. However, a choice showed that it's increasing dimensions till 25 years. But we can see that the scalar incidence in the Sella turcica dimensions during puberty, calculated by means of growth rate increments, could also be detected in the longitudinal material for depth, the greatest diameter, but not for the length for this study. And according to the most of authors' opinion, it's in the skeletal development increased rapidly during puberty, so we divided our patients' radiograph for two different age groups, 6 to 13 years and 14 and above. So several investigations in the literature focused on Sella turcica size and morphology with different types of syndromes, but limited number of studies found Sella with unilateral and bilateral cleft palate patients. According to the Nielsen, they show that the maxillary areas were shorter and asymmetric in unilateral cleft and palate patients, not unilateral cleft lip patients. And severe deviation observed in the newborns. This study working on newborns, and with unilateral cleft and palate patients, morphology were different. According to this study, they showed abnormal morphological appearance of the Sella Turcica can be found in majority of the cleft subjects when compared with normal subject. With age and increase in their dimensions, appeared only occur as age increase in both non-cleft and cleft subjects. So, we have some, our results are agreement with the previous studies that in younger age group for Sella size, cleft lip and palate patients have smaller size on Sella Turcica. However, older age group for the right unilateral cleft group were showed no significant difference with control group. For morphology, for the younger age group, the abnormal shape was really high, and normal morphology percentage for unilateral cleft group for all two groups for 15%, and for bilateral group it was 20%. But again, for the older group, unilateral cleft group was higher normal morphology. So the reason of these changes through adolescence, during the puberty, pituitary glands reach the maximum size. And this incremental activation of the pituitary glands affects the surrounding bone structure. So due to this association, we attributed present studies to the most functional matrix theory. Activation of pituitary gland affects the smaller size and this morphological appearance, and this leads to growth positive way for also size and morphology. So as a conclusion, I want to tell these points one by one. Sella Turcica size increasing with age for all patients, all people, all individuals. Cleft group has smaller size compared to the control. These differences reduce with age. Sella size are getting bigger on cleft patients, but could not reach the normal size, mostly. The morphology differ from the normal in the cleft subjects, while control group individuals were widely seen normal morphology. Those differences reduce with age, and normal morphology increase in older group for all cleft groups. Any alteration, this is the exact point for this is really important result for this. Any alteration on Sella Turcica size and morphology causes the change its position and misleads the clinician about the diagnosis and treatment plan by changing S points. So new specific cephalometric norms will allow more accurate diagnosis and treatment plan, especially for cleft patients, considering the difference observed in Sella Turcica size and morphology compared to the normal patients. So when a difference observed in Sella size and morphology on lateral cephalometric radiographs, this should be considered the pituitary gland function could be affected. In particular, cleft and palate children with short length need to guide for the examine various endocrinologic testing. So it's the plan that we should do more extensive studies with larger sample and compare size and morphology, comparing necessary endocrinologic and genetic testing during investigations. Thank you for
Thank you for your presentation. Does anybody have any questions for Ms. Karsli? Anyone? That's all right. Thank you. We have some technical break at 2 minutes. All right, so please welcome our next participant, Dr. Filipa Braga, and she will tell us about digital dentistry in complex cases. So please welcome her.
Hello, everybody. Thank you so much for having me. So I'm here to talk a little bit about digital dentistry in complex cases. We all know that technology has come to stay and is kind of changing the world. And we also know how it does apply to dentistry. We have intraoral scanners, the CBCT, everybody's talking about 3D printing and CAD/CAM technology. And these tools are not here to change dentistry. They will just help us improve the way we treat our patients. And today I'm talking a little bit about surgical from all this technology. And they are static surgical templates that reproduce virtual implant position directly from the CBCT. So you all know this, the implants are planted in the CBCT and then translated to these guides. But are they good? These are some of the advantages of the surgical guides, which are the accuracy of the implant placement, the fact that it allows for less risk flapless surgery. They also allow for a reducing of surgical time and obviously the decrease of post-operatory pain. And also a big advantage is the integration of the restorative treatment plan. So we can actually do immediate prosthesis before surgery and before actually seeing the patient. So there are two types of guides. We have partially guided surgery and then fully guided surgery. The major difference is that partially guided surgery is the guide that guides the osteotomy, and we have to take it out and then place the implant after. As well as the fully guided surgery, we place the implant through the guide. So it's obviously more accurate than the partially guided surgery, but still both techniques are used nowadays. Everything is still in development. But I'm going to show you the first case we did at White Clinic in Lisbon of fully guided surgery. So let me introduce you Leopoldina. This is a little dark. This intraoral picture. This is a 58-year-old female with no teeth, so full dentures. Can dim the lights. Maybe it will help. Better?
Yeah.
So I'm gonna walk you through this fully guided surgery we did like 3 months ago. So this is Leopoldina, full dentures. She went to the White Clinic wanting fixed teeth. So the first thing we did was a DSD protocol where we do some videos to do the aesthetic study and to guide ourselves through the provisional prosthesis. So here is the digital smile design, the 2D smile design, the changes we wanted to make in the provisional prosthesis even before we did the surgery. We showed this to the patient loved it, so we said yes, and we worked with a lab in Madrid that started producing all the digital planning. So this is a merge of the CBCT, the stone models, and also the new design for the new prosthesis, all in the same software. Here we can see a little bit in fast motion how it works. So it has a lot of different features, and we are here planning the implant's position, and at the same time the provisional prosthesis position, and you can see we can check the occlusion also, so it's meant to be almost perfect with the less touches possible in the mouth. So we saw the scanning, everything was okay. 4 implants on the top, 4 implants on the bottom, doing like the all-on-4 technique. We said to the lab, okay, so this is here they are printing the models and the guides. So one day after, this arrives to our clinic in Lisbon. This is the surgical guides, and here the provisional prosthesis. We can see that it has some fixation pins, so because the surgery is going to be fully guided, the prosthesis will be fixed as the surgical guide in the same fixation spots, so it will be almost, you don't need to touch the provisional, that's the goal. We still need to touch a little bit, but I'm going to show you how. The first thing we do when patient arrives is to place a fixation pin guide. So we place these guides and we ask the patient to bite, and this will guide us to do the fixation holes that will fix the implant guide and the provisional prosthesis that we're going to build. Here you see the fixation pins, and now the implant guide. You can see in the small images that we are drilling through the holes. These metal rings are the ones that give the angulation perfect. And here we are placing the implants through the guide, which means this is a fully guided surgery. After that, we are taking out the guide and measuring the ISQ, because we want to do immediate loading in this case. So we need to have a big ISQ to do it, which is implant stability coefficient. Here in the bottom, we are placing the implants through the guide also. And here are the provisional prostheses after pickup. So we need to do acrylization in the mouth. It's not possible yet with the lab we work to do it like just to screw it in. It's not possible. There's always little deviations. And here is the final provisional prosthesis, and here's patient after surgery. And this is where the Lipulina is at the moment, because we are still waiting for healing time to do the final prosthesis. So this is final panoramic, and here is superimposed of the planning of the implants. And we can see that it's not 100% accurate, right? You can see the green implants are not exactly where the white implants are. So how can we trust these guides? How can we know the real accuracy of these surgical guides? Because we want to know the real accuracy of this technique, we developed a study at our clinic where we compared the implant position plan, the planned position with the real position. And we came up with some results that I'm going to show you now. So here we can see the green are the planned implants, and the pink, purple are the real implant position. So it's not one over the other, right? So what is this? What's the accuracy of this? Okay. So we studied 4 patients, 36 implants on these 4 patients, and during 6 months. All surgeries were performed at our clinic in Lisbon by Dr. Miguel Stanley in this case. And the 36 implants were from Megagem brand, any rich type, and were all placed with a 15 Newton torque and with an ISQ of over 63. The study of the superimpose of the 2 images was performed using a software called Nemo DSD with the help of our colleagues in Madrid. So here we can see a little close-up of how they are looking at this. So the measures are, they measure 3 points from the green to the purple. They measured platform position, comparing the platform of the planned implant with the platform of the real implant, the post-op CBCT. And the average deviation of our 36 implants was 1.99 millimeters. Then we compared apex position, exactly the same way, and the average deviation was 2.02 millimeters. Finally, we compared the implant axis, so implant angulation, and the deviation was of 6.19 degrees. So then we went and compared with other studies that exist to see if these numbers what were their significance. So the story in 2014 published a study with 1.9 to 8 millimeters deviation of the apex position and 4.9 angulation deviation. And then in 2007 and 2008, other two studies with 1.1 and 1.5 millimeters of apex deviation and 2 and 7.9 angulation deviation. So we know that our values are in the average of the studies, still a little bit more deviation in our studies. Why is this? So why do we have such a big deviation in these studies? Because 2 millimeters in the mouth, it's a big distance. So there are some reasons. It's an ongoing research and a technology that is still evolving fast, but is still evolving. So we know that we need to know the reliability of the 3D reconstruction software. There are good and there are not that good softwares that may influence. The quality of the CBCT also obviously influences the results. The accuracy of the 3D printing, because the guides are 3D printed, so we also need to have a good printer. Of course, we need to count with the laboratory and technical errors. The knowledge and the experience in CBCT analysis of the digital planner. In this case, all implants were planned by dentists. We also need to count the radiation artifacts, quality of the prototype, the material that the guides are made of course, the surgeon technique, the operator positioning error. This is more for the partially guided surgery, because in the partially guided surgery, you need to count with the angulation of the insertion of the implant, movement during the surgery, and of course, interpretation of the CBCT and with the planning. So the difference between partially guided and full guided is still big. In our particular study, the reason why the deviation is a little bit bigger than the literature, it's basically because only 8 out of these 36 implants were placed with full guided surgery. Only the Gudinas one, for 8 from bottom. Another reason may be the implants we used, we were the first to use these implants with these guides. So we have a learning curve and we need to talk with the lab, and it's not even 100% accurate, the implants with the software. Another reason is only 3 of these 36 implants were placed using tooth-supported surgical guides. When you have tooth to support, you minimize the movement during the surgery. We need to count the surgeon skills, because in this case, the surgeries were performed by Dr. Stanley, and sometimes he would just take the guide out and place a longer implant or an implant a little bit further, a little bit as his experience tells him it's best. So this also happens, and it contributes to the deviation. And some of these cases that I showed you had simultaneous guided bone regeneration, and this obviously interferes with the implant position too. So basically, the results, we know that surgical guides enable more precise, accurate osteotomy than non-guided approach implants. We also know that this study showed that guided surgery implants are comparably with the previous studies. And we know that totally guided approach will offer greater results than partially guided surgery. Finally, some future directions for guided surgery. Of course, the improvement of the CBCT image, to only do fully guided surgery, and to integrate live navigation surgery technology in the future. Thank you.
So thank you, Ms. Braga, for such an amazing and impressive presentation. And anybody have any questions for our presenter.
What are the costs for printing one guy for one job? What material costs and then the...
Okay, I can only answer you the costs of the lab, so I don't really know what are their costs, but for us, the guides and the provision of prosthesis costs 500 euros.
Including the both templates and
the guides and
just one guide. Take it out or no the price? One Joe guide.
I don't know.
I saw you use object 3D. It's a biomaterial material.
The material they use, it's a resin. Yes, it's photopolymerized resin. I don't know the specifications of the material, but I know that it's resin.
Who's designing those?
Okay, this is designed in a lab called DST Lab. It's in Madrid, and there are actually many junior dentists behind the computers. So of course they also have IT technicians, of course, but the brains behind this are all dentists.
Do you think it's natural, or it's good that the brain behind will be ones you design templates, the things, or do you think it still needs to be someone else, the IT guy or somebody with designing skills?
Okay, I think we need to be able to plan our own surgeries. The thing is, the software is not there yet, so if I'm in front of the NEMO DSP software, I wouldn't be able to plan my own surgery because I'm not familiar with the system and I don't have the time to be. But yeah, of course, I think there will be different and more user-friendly software that will allow all of us to plan our own implants.
You said there are two types of guides, fully and partially. I noticed one has sleeves and one.
Yes.
What is the rule of the sleeves?
So the fully guided surgery has the rings, the metal rings. That's what we're talking about, right? Yes. Okay. So the metal is more accurate than the resin, the plastic. So although they have the same function, which is to guide the drills.
How accurate?
How accurate? It depends.
I mean, it plays in the direction or in depth, or it stops the
everything. The ring guides everything: depth, angulation, and position. Everything.
And why it's only in the fully, not in the partial?
The difference between the fully and the partially is the depth.
Okay.
So the fully guided has exactly the depth where you put your implant, whereas the partially doesn't. You need to prepare the depth with the guide, so it has a stop with the depth for the osteotomy drills, but then you are the one who decides the depth of your implant. It's not decided on the guide, whereas fully guided, you have the depth determined before.
Thank you.
That's the difference.
Only one question. You, all the CTs that were used to plan all these 36 implants on the population, were they because the same machine?
Yes.
Thank you.
Oh, thank you, Ms. Braga. And please welcome our next participant, Nikita Salnikov, who will tell us about the advantages of ceramic micro-inlays.
Good afternoon. My name is Nikita Salnikov. I'm from Saratov State University. Today I'd like to present my report on the advantages of ceramic micro-inlays in treatment of carious lesions of dental tissues class 2 by Cleft. So, how to press what button? Thank you. Dental materials and technologies are developing very rapidly. So Their quality and characteristics are improving all the time. However, the restoration of tooth contact surfaces sometimes can make some problems to the doctor. The purpose was to study the benefits of using micro-inlays to restore carious lesions of hard tissues of class 2 white leg versus filling composite materials. Several databases were examined in order to find any articles about characteristics of up-to-date composite materials, their characteristics and their usage. Besides, we looked for the results of the researches, clinical researches, for the restoration of proximal surfaces with them. So we have some results. Someone, how to say, English is very bad, you know. We found out that many authors claim about lots of disadvantages of composite materials, such as dentists can sometimes mistake when choosing the composite material or violence the protocol of preparation or bonding. So these materials have shrinkage. Moreover, the coefficients of thermal expansion of the fillings and the dental tissues are different. So we have also to take into account polymerization, stress, masticatory loads, hydrolysis attack, and reactions between tooth tissues and chemical compound of the material. All these factors lead to a sufficient result of tooth restoration with composite fillings. So ceramic inlays can solve such problems. They are firm, they contain no unpolymerized bond left, so as composites can have about up to 20% of unpolymerized bonds. They are so they're aesthetics and functionally at the same time, so it's very good. Finally, they provide better hygiene. They not accumulate blood on it, and it's common to tissues. So to sum up, due to the low elastic models of composite restorations materials, this cannot compensate for the loss of strong proximal enamel crests in cases with large class 2 restorations in particular. In such cases, it is strongly recommended to use micro-inlays than composite materials. So thank you very much. Micro-inlay? I don't know how to explain it. I can explain it. It is ceramic micro-inlay.
I wonder what the micro means, but okay.
I can, yes.
As opposed to no, if you have no micro.
You can say to apply in Russian and you can translate.
Суть вопроса, что такое микровкладка?
Почему там есть слово микро? Чем она отличается от обычной вкладки?
Ну, она отличается тем, что, во-первых,
how is the micro-inlay different from any?
What is the difference? Yeah. So I think that we have in two types of inlays. It is культиваешь-чистовая вкладка и can you translate it? I don't know how to translate to English.
What he's trying to say, there is a difference between the two kinds of inlays. One where they pass into the root canal, they call postcode.
That's an endocrown. Huh? That's an endocrown.
Yeah. And the other one is a micro-inlay in this terminology.
So I think
A micro is what is?
micro. So we can call it like inlay, but we call it in Russian like micro-inlay.
Okay,
so I
we don't know what
translate it like this.
Yeah, we don't know what that means, but that's okay. And I'm wondering why you didn't talk about also disadvantages of these inlays?
Disadvantages. I will think about it.
Yeah,
and I will add to my.
For example, disadvantage is you can't have undercuts, for example. That's an advantage of perhaps composite versus so it's just keeps it more balanced.
Okay, thank you. Thank
You
you.
think about that.
Thank you, Mr. Thomas. And our last participant is Shayan Davish, who will tell us about the morphologic and mechanical properties of T lymphocytes in children and adults by IADS.
So, in the name of God, today I have the honor to present you the recent work that me and my professors have been doing lately. It's about morphologic and mechanical properties of T lymphocytes in children and adults using AFM or atomic force microscopy. As we may all know, periodontitis is an inflammatory disease and the most common chronic inflammatory disease in the mankind. And if we include gingivitis as well as periodontitis, it affects up to 90% of the world's population. What will happen if we let it go? It will result in bone loss, tooth loss, and finally tooth loosening and tooth loss eventually. This inflammatory response, which it includes immunological functions in it. That these immunological and inflammatory responses together, they have both a protective and a destructive effect on the host. Now, in these periodontal lesions, we know that the T lymphocytes have an active role, and that's because of the higher expression of their markers, like CD25, in the periodontal sites. And although they have been studied before, like immunologically and biochemically, they have never been studied in a mechanical way, and their mechanical properties have not been studied. And that's because we didn't have a sensitive technique to do it. But now we have AFM. And if, as you may all know, cell membrane has an important role in also the immunological functions because it happens in the cell membrane and between the interactions of the cells, cell adhesions and stuff. And this cell membrane is affected by the intracellular architectures and cell cytoskeletons. And they actually tell the cell how to behave and how to shape, where to have adhesion. What is AFM? AFM, or atomic force microscopy, is a very powerful tool to study the nanostructural details in a non-destructive way, which means we can study cells in their life forms and not using the pathological fixations to actually destroy the cells. We can study their life form. And AFM is a kind of an SPM, scanning probe microscopy, which was first invented in 1982 by Binning and Rohr in Zurich, which they won the Nobel Prize for that. In 1991, the first nanoprobe and nanosensor was developed, and finally in 1998, the commercial AFMs were developed by Stanford researchers. This is a schematic picture of the AFM, because as it touches the cell, the laser is twisted, and then it touches the sensor, and then it reflects and goes to the detector. And it touches, as you can see in this animation, when the sample or the cell surface is as it is touching it, the reflect laser will touch the detector at different places, and then the data will go to the computer and gets assessed And finally, by some formulas that the company that produced the AFM, we can assess the results and have the mechanical properties results, which I will explain. This picture is from one of our related articles, and I'm going to put it here just for you to have a better imagination of AFM and how it works. This study has studied T lymphocytes in different stages: the apoptosis stage, the activated stage, and the resting stage. And when the probe of the AFM is actually touching the cells with the same amount of force, we can see that they have different elasticity, different flexibilities. As you can see, the apoptosis cells have less elastic modulus or Young's modulus, which means they were more flexible. And the activated ones were the most stiff one, which means they had higher Young modulus or elastic modulus. This is a picture of the AFM we use in our university. Now, review of related articles. Some of the related articles, I have just put like some of them here, there were many. One of them is about human neutrophils. They have studied on human neutrophils and they have shown that the reassembly of the intracellular protein networks can actually regulate the cell shape, the cell behavior, and the cell function by telling the cell where to have adhesion and different flexibilities like elastic modulus. Then in 2006, a study was done on T lymphocytes and their adhesion, measuring the adhesion of them to the endothelial cells. And we have another in 2009, which they showed that they use also AFM on the T lymphocytes, and they studied the different stages, like exactly the picture that I showed you was from this study. Now, what is our objective? Our objective, as I told you, periodontitis is an important disease for us. T lymphocyte had an active role in them. Morphological and mechanical properties of them have not been studied yet. So we're going to study them and compare the T lymphocytes between the periodontal lesions and the healthy patient tissues, and also we're comparing children's and adults, and also the T lymphocytes in blood and tissues. And our hypothesis is that the AFM won't be stated as a unique technique to study the mechanical properties, and also that there is no difference between the mechanical properties in different groups. How we did it? The tissues were collected from patients who required crown lengthening surgeries, and also our blood specimens were collected from the donors, healthy donors, and also from healthy donors who only had periodontitis. So our patients were drug-free and did not have any systemic diseases. And then the periodontal status of these lesions were assessed by a specialist and categorized into aggressive periodontitis, chronic gingivitis, and also healthy tissues. And we also have blood T lymphocytes, which were from healthy and also from patients who only had periodontitis. Then we collected the mononuclear cells from the other cells, and then again collecting the T lymphocytes from the other mononuclear cells using the negative isolation kit. And then we fixed the cells with glutaraldehyde 1.5% on plate, which is totally different from the pathological fixations because they have like different concentrations for fixations. This fixation will not actually like destroy the cell, and we can also still we can study them with the live work. We studied the surface roughness and the Young modulus, which are the most important aspects of the mechanical properties. And from each group, 4 to 5 cells were selected randomly and probed 5 times, which means 5 cells from each group, 5 probing, which will give us 25 data for each group, like aggressive, chronic, healthy, and blood specimens. Then we assess these data using this formula and the force distance curves, which the most famous one that the related articles also use were the Hertz model. And we calculated the Young's modulus. And to study the consistency of our results, we used t-test using the Excel software, and we had a significance of a p-value less than 0.05. This is the results of our study. As you can see here, adult tissues has the most, adult healthy tissues has the most and highest Young's modulus, which means they were the most stiff one. And as the disease becomes more severe and severe, we can see that the Young's modulus is decreasing with it. So first we have gingivitis, then chronic, and the most severe form of the periodontitis, which is aggressive, has the least Young's modulus. But that's just for the adult tissues. Comparing the child tissues to the adult ones, child tissue even had lesser elastic modulus comparing even to the aggressive one. And if you pay attention to the blood groups, comparing to the whole tissue groups, they have less elastic modulus than the whole tissue groups. And that's maybe because they're supposed to be flexible, because they're in the blood and they're supposed to move and supposed to be flexible. These are the results of the surface roughness, which I can't study due to the lack of time, but I'm going to show you the pictures that we took from T lymphocytes using the atomic force microscopy. The first 3 on the top were taken from the tissue specimens, but the 2 in the bottom were taken from the blood samples. If you pay attention to the size, the T lymphocytes in the blood group are much smaller in size compared to the tissue ones, which again may be due to that they're supposed to be smaller because they're in the blood. So cell motility is a mechanical phenomenon, and little studies have been done on the movement of the cells, on the mechanical properties of the cells that they have been done. Also, other studies have been done on the fibroblasts that prove that AFM can be used, and we also proved that AFM can be used as a very useful way to study these mechanical properties. Other results were that the stiffness distribution on our cells were quite constant in the cells that were stationary. But as the cells were about to move and start to move, the nuclear part had a gradual decreasement in the elastic modulus, which may be used in the cancerous cells that, as a sign that the cells are beginning to have movements. In 2006, one of the researchers, group of researchers, studied also erythrocytes in patients having different anemias, and they had a result that the pathological erythrocytes had 2 to 3 times higher Young's modulus compared to the normal ones, which is totally in contrast to the result of our study. And that's maybe because that erythrocytes originally were supposed to be flexible. A comparative study of normal and cancerous cells have also been done that showed that the normal cells had a 1 order higher elastic modulus of the pathological one, which is in line with the study results of our study. And these are all maybe due to the, as I said, cytoskeleton organizations and their contractions with the extracellular matrix. So totally, conclusion, the more the motility, the less the elastic modulus, and the more the inflammation, the less the elastic modulus. And the results of our study may be the first step studying the mechanical properties of T lymphocytes. And so they can be used in the future studies of the T lymphocytes and the mechanical properties, and also in other fields like medicine and mechanics. And also these results can also be used in inflammatory studies in the future, and also cancerous studies using AFM. Thanks for your attention. Are there any questions?
It's very interesting idea. What you're doing. I'm just curious to know if any analysis of the cytoskeleton was done, like any mRNA, PCR, just to know any change in the cytoskeleton.
You mean actually studying and also biochemically,
or it's due the young models changing due to the precipitation of some of the
we actually haven't studied the cytoskeleton like inside, so we only studied the AF, the mechanical properties, the surface roughness, and the Young's modulus. So yeah, that would be like a good idea to, yeah, we can try it in our next studies. Yeah, but unfortunately, yeah.
It's a cool.
Yeah, I get that. Why is it actually that's easy? Maybe in our future studies. Yeah. Because, yeah. Any other questions? Thank you.
Thank you. So this was the last presentation. So I can announce the 15th IADS lecture contest over. I want to thank all of you for coming, and I want to especially thank the jury so they could find a time in their busy schedules to come here and be present at our student conference. So thank you so much, and I want to thank the LOC as well. The Barbara did an amazing job organizing that conference, and especially I want to thank the Michal, with whom we worked a lot on this scientific program, so to make it happen. So thank you. The results of the lecture contest will be announced tonight after we will count the votes of the jury. So thank you for your attention. Yes, Yeah, I guess so.
Hi guys. Have a nice day. Bye.
By the way, I want to for the party. So it's difficult because of it.
Yeah, it's different types of studies.
But it was really nice.
That's quite specific things that are used.
Which you like the most?
Yeah, they could make it simple things some of the presentations, the connection between the someone says that to prove something and to put it in the expression.
For me, the one which was very well structured, everything like was Sella.
It's not Turcica.
Following every we follow I'm so interested.
This last one. the presentation is the structural text. There's too much text on the slides, and it has a difficult topic. He should concentrate on readability. Unfortunately, it was the last, so it was I had a problem to concentrate on his presentation. Despite his speech was correct.
Just measuring what was he was specific and the size of morphology because it's a substrate.
And the subject is and mechanical because mechanical is more
literature.
The Invisalign guy was saying that.
Thank you very much. If I can ask you, what is Invisalign?
That should be
It's very hard to choose specific. Seriously, some of those titles are crazy.
This is just an specific. I mean, it's a small context. Even the outstanding, you think they will have, but yeah, what's the way of that? More ethical and the quality of work will be and this also MDI. I mean, all of them, somewhere in September, so I think you are really flawless all the studies and charts that clinical skills are in different topics. It's fun, it's science.
It's easy.
Yeah, of course.
But there was a university, but not all the things that are starting. Biological background. Sure, you know what you know that
These are really free in world.
Facciamo 15 minuti da
Thank you. Thank you. Thank you for coming and dedicating your time to you.
Thank you for inviting me. It's wonderful. Very interesting.
You know, if I can ask, if you have any comments on their works or on their presentations, can you write it somehow and send it to me so I can?
I wrote my comments on the that was to me. But I need to maybe make my comments.
Yeah, I think it's looking forward.
I can
if you scan my comments
and send it to you to make a full.
If you want.
Yeah, of course.
And that's maybe a good basis.
It's good feedback for them so they can learn and make it better next time.
This will be very effective using data
Yes, it was very much if you can do the same.
But I won't remember unless I see what. And you won't be able to read my mind. It was just for me.
You can take pictures of the papers from
this one.
Yeah, these are the name of the instructors here. So you can
Oh, see, you'll never be but I understand. I understand what you're saying.
Oh my God, this is.
It's just for me so that I can just make, sense out and remember what I saw.
All right. Thank you.
Thank you very much. Well done. Okay.
So see you in the other middle.
Lecture, I think.
So, I'd like to.
Seriously?
We will.
No, not that.